Welcome to our egg freezing webinar tonight. First of all, just wanted to thank you for spending your evening with us. Tonight we have Dr. Liyun Li. She will talk us through the egg freezing process at PFC. During the webinar, you may send questions through the Q&A feature located at the bottom of your screen. You can submit questions anonymously, and then I can go ahead and send those to Dr. Li personally. All right, and as a thank you for being here tonight, we are offering a $99 new patient assessment for patients who do not have insurance coverage. All right, and then Dr. Li, the floor is now yours.
Thank you, Anthony. Hi, everyone. Thank you for joining me today to talk about egg freezing. We are at Pacific Fertility Center, and I've been here for about 13 years. I work with my colleagues, Dr. Isabel Ryan, Dr. Jennifer Agard, and recently, actually already been about 4 or 5 months, Dr. Strug, who has joined us from Stanford. So we're very pleased to welcome him, and we work with a very good team, and hopefully you'll get to meet one or all of us through your journey here. A little bit more about me. I joined the practice in 2011, like I said, almost 13 years ago, 14 years ago. And I did my OBGYN training at UCSF. So I spent a few years in San Francisco getting to know the fertility community here. Then I did my reproductive endocrinology and infertility fellowship in New York at Columbia, where I learned a lot from my mentors and also kind of learned how IVF is done on the East Coast. But, you know, me and my family are definitely more drawn to the West Coast. So we decided to come back here and established our base. And I've been so lucky to be part of PFC since finishing fellowship and developing my home here. So today we're going to go through several aspects of fertility preservation. We're going to talk about testing and fertility workup. We'll go over the actual process logistics, and I will show you some of the published success rates as well as our own internal data. Why egg freezing? You know, this used to be a question that was novel maybe a decade ago, but nowadays I feel like general education has gotten better. People are more aware that our fertility is decreases with age, and as more and more women delay conception, it becomes an actual issue for a lot of patients. And egg freezing and embryo freezing is a technology that is able to help us preserve our fertility to a certain extent and improve women's choices for the future. So these are just kind of demographic data. Over the last 20, 30 years, you can see a shift in the age of being first-time mothers. In the early 80s, most people end up getting pregnant in our 20s, but nowadays you can notice a shift to the right. The age of first-time moms are in our late 30s or late 20s, early 30s, and in the Bay Area, actually, first-time moms median age is in our mid 30s, and that becomes a challenge for a lot of women who didn't have fertility issues before, but all of a sudden finding themselves facing trouble getting pregnant, either for their first baby or their second baby. And egg freezing is really just an amazing solution that can kind of take a little bit of pressure off and provide patients with additional options. Again, so like I said, overall first-time mom, actually, I thought it's mid 30s, but it's still a little bit younger than I thought, but still in our early 30s. And we have the oldest age for first time birth in the nation. Now, what does age have to do with all of this? Well, um, our paradigm in our field is that our eggs in our ovaries decrease in quality, and that leads to decreased chance of pregnancy as women get older. So this is like the sentinel studies, um, and looking at fertility rates and age of the woman. And each of these lines represent a population, historical population in different, of different ethnicity and different location. And you can see some of these population, these are historical data that came from like, the 1600s, 1700s, 1900s. And these data are interesting because this is before the age of contraception or effective, birth control or termination. So it's kind of as close to natural conception as you can get. And these populations of people tend not to travel too far away from their community. So it's fairly pure data. It's very hard to look at natural fertility now because pretty much everyone's is on contraception before they are ready to conceive. And because of IVF and because of egg freezing, it's, you're not going to be able to get that type of pure data. So critics complain about how this is too old, but to me, this really is very reflective of our biology. So as women get older, you can see kind of the point of reflection here is around mid-30s, 35, that the fertility significantly decreases. And then by our early 40s, it becomes very difficult to get pregnant. And if you look at actual complications with pregnancy, for instance, miscarriage, we also see the same curve except it's flipped over. So as women get older, our miscarriage rate increases. And this is true both in natural conception. We also have data in fertility treatments in women who have received fertility treatments like IVF and IUI that risk of having a miscarriage increases as we get older. Now, this can be fixed in modern day IVF when we do genetic testing on the embryo. So it's, in some ways, this is no longer the case with IVF pregnancy. But we still see an age-related increase in pregnancy complications as we get older. Now, this all boils down to the fact that we have limited egg supply and our eggs are never replenished. And as we get older, we lose eggs. So we lose eggs over time. And by the time we're in our mid to late 30s, we are already, 90% of our eggs or 99% of our egg supply has been depleted. How do we assess fertility or ovarian reserve? How do we assess our egg count and egg quality? Well, egg count is best assessed by a blood test called anti-Müllerian hormone. And it's also can be counted on ultrasound. We can see immature follicles, immature eggs on ultrasound in our ovaries, and that gives a good assessment of our overall quantity of eggs in the ovaries. Now, quality is a little bit harder to assess. We also know that egg quality decreases as we get older, but so far there's really no good test, hormone level, et cetera, to tell us what the quality is or predict what our egg quality is. The best predictor is still age. In terms of egg count, this is what I'm talking about when we are speaking about ultrasound assessment of egg count. So antral follicle count is the medical term. Here is an ovary, and these black circles, each one is an antral follicle. Now, black is fluid on ultrasound, so this is just little pockets of fluid. Inside is an immature egg. The egg is microscopic because it's only one cell, so we actually cannot see the egg itself on ultrasound, but what we're seeing is follicles of this particular size. And every month, our body wake up a group of deep dormant eggs, and they grow to the point where they are actually, the follicle is about 2 to 10 millimeters on ultrasound where we can see them. And biologically, the eggs attain the ability to respond to our hormone signal to ovulate. So, and in a natural cycle, our body pick one out of this group of antral follicle to ovulate. But all of these follicles are potential ones that could be picked to ovulate. And one gets ovulated, and the rest will compete for ovulation, but they don't make it, and they'll die at the end of the cycle. And it turns out how many eggs in this cohort is reflective of our overall ovarian reserve. Okay, so this is a picture of an ovary with a lot of antral follicles, suggesting high egg count. And this is a picture of an ovary here with only one antral follicle. So this patient has low egg count. So when a patient comes to PFC for a fertility evaluation, whether for egg freezing or IVF, one of the tests we will be doing is a vaginal ultrasound to do an antral follicle count. Another way to assess egg count is by this hormone called anti-Müllerian hormone, AMH. It's a blood test. We look at serum levels of AMH to use that as a correlate to ovarian reserve or egg count. Because AMH is actually produced by the antral follicles that I just showed you on the ultrasound in the last slide. And we see that if you track lots of women through their reproductive age and look at their AMH over a matter of years, we see that, again, this curve is very similar to the fertility curve as a function of age. So as women get older, average AMH decreases, suggesting decreasing egg count, and kind of, the age at which the AMH decreases is correlating to the age at which we find it becoming more difficult to get pregnant. The other useful character for AMH is that it's actually fairly independent of our menstrual cycles, because the antral follicles are always there. Every month we have a group and they all are kind of hanging out, each one secreting AMH. And so we don't have to go get those labs done on a particular day in our cycle. So it's a very convenient test for a lot of women to do. And we find that for most part, it is not too affected by birth control, IUD, or contraception, although individual patients can be a little bit different. But as a screening test to just get a general sense of your egg count, AMH is a very good test. Now, in terms of for fertility preservation, I just want to put in a couple of words about, we tend not to think about how to protect our fertility, even though we talk all about, egg freezing, saving our eggs, trying to get pregnant sooner rather than later. But in the meantime, as we are trying to kind of not think about getting pregnant, it's really important to also reduce risk of sexually transmitted infections, reduce unplanned pregnancy, because any one of those can decrease the chance of pregnancy in the future. We want to stay healthy, with nutrition, fitness, stress management, but we also want to know our family history, because if there's a family history of genetic diseases, et cetera, then it's good to know about it ahead of time and potentially do some testing, knowing that if something gets discovered, we have you have time to plan conception, plan future genetic testing, etc. Okay, so the egg freezing process at PFC, there are multiple clinics in the Bay Area and of course throughout the country. So patients have a lot of choices. And at PFC, we really try to make the egg freezing process more individualized, and we try to streamline as much as we can. So most patients will work with a team, including doctors and nurse practitioners and coordinators and nurses, to make sure that every step goes smoothly, but it can still be a complicated process. I'm just going to briefly go over the actual logistics. Okay, now before we get into that, egg freezing is a very layman's term, colloquial term. The chemical reaction is called vitrification, the chemical process. Vitrification is a rapid cooling process whereby the entity goes from a liquid state to a solid state, and it bypasses crystal ice crystal formation. And that actually can help preserve the integrity of the biological entity. We first started using vitrification with embryos, probably about 20 years ago. And we find that embryos survive freeze and thaw much better with vitrification than with slow freeze that we used to do, to the point where now pretty much 100% of the embryos that we freeze will survive the thaw. And when we first started freezing eggs, we were using slow freezing, and we found that more than half of the eggs that we freeze will die. And as we get better with vitrification, we started utilizing that with eggs. And by eliminating the stage of ice crystal formation, it allows the eggs to survive the freezing process much better. So now egg vitrification, we are looking at 80 to 90% survival. So the patient journey begins with that initial consultation and screening. Screening means that we do the ultrasound to look at the egg count. We do a blood test called the AMH to correlate with the ovarian reserve and get an estimate of how many eggs we might be able to retrieve. Sometimes we incidentally will diagnose a patient with no history of infertility at all because they're just trying to freeze their eggs, but we can incidentally diagnose a low ovarian reserve because a lot of our patients are already in their 30s. So it's not inconceivable that you could already present with a lower egg count. So it is important to get the screening done and help us set expectations of what to get per cycle and potentially how many cycles of egg freezing we need to do. The other pre-cycle screening test is to prepare the body for the procedure, like blood count to make sure you're not anemic. We also will do sexually transmitted infections because freezing of or storage of any biological tissue should be associated with all the communicable disease results. So the coordination and testing is done with by our team of coordinators and nurses. And we also will have a class where the nurses will lead to review all the medications and complications and just kind of go over some medical aspect of the egg freezing process. And then the patient will work with the coordinator to set up a calendar and also work with insurance or our financial department if you're self-pay and to get medication ordered and learn how to do injections. And then the patient wait for their baseline ultrasound. Typically, the baseline ultrasound is on the second day of your period. For patients who are already on birth control or on the IUD where they're not getting periods or they're not ovulating regularly, we can kind of decide mutually on a random day that's not associated with a cycle to do that baseline ultrasound. The goal at the baseline ultrasound is to make sure we don't have a cyst in our ovaries and that all the follicles or the eggs are small and ready to grow. We'll also do a blood test at the baseline ultrasound, again, to make sure the hormone levels are consistent with follicles being quiet and ready to go. So after the baseline ultrasound, typically that evening or sometimes a few days later, we will instruct the patients to start fertility medications. And these are injections that you're going to take every day for about 10 to 14 days. So I typically tell patients, anticipate 2 weeks where you're going to be taking daily injections. And those injections are to stimulate multiple follicles to grow in our ovaries. And during this 2-week period, anticipate coming back to the clinic about 4 to 5 times for ultrasound and blood tests. We call these monitoring appointments. It's to monitor the growth of the follicles. And At the end of this 2-week period, again, roughly 2-week period, where the eggs and the follicles look like they're ready, we will then instruct the patients to do one last injection, the trigger shot, and then 36 hours later, the patient will undergo the egg retrieval procedure. Okay, so now a few words about fertility medications. So these are essentially pharmaceutical, like uh, produced or drug company produced follicle stimulating hormone. Now, our body naturally secretes follicle stimulating hormone at the beginning of our period to stimulate one follicle to grow and ovulate. So we utilize this hormone, except it's obviously made in the laboratory for injections, and the follicle stimulating hormone injection will get not just one egg to grow, but multiple eggs. And in fact, our goal is to get every single follicle in that antral follicle cohort to grow. And usually majority of the follicles will grow under daily injections. And the injections have to be maintained, because if you don't maintain the injections on a daily basis for that, until they're ready, the follicles will end up regressing and shrink back. So the injections are done using a small needle that goes in the skin of our stomach. So they are subcutaneous medication or injections. And like I said, we'll have classes to teach patients how to do the injections, as well as a video instruction. And like I mentioned, it lasts about 10 to 14 days. Now here is kind of some diagrams and a video of the egg retrieval. So we will do the egg retrieval with a vaginal ultrasound, and there is a needle that's attached to the ultrasound probe. And the needle goes through the vagina into the ovaries, and the follicles are inside the ovaries, and the needle goes inside each follicle, aspirate the eggs and the fluid, and it's collected in this tubing, and the fluid is assessed and looked under the microscope by our embryologists, where they can gather all the eggs. So here's the ultrasound. Here's a ovary with large follicles, stimulated follicles, and here's the needle. And I have a video here, so let me see, just make sure. So here's the ovary and here's the needle. Okay, I'm just gonna play. So you notice the needle going into the follicle, and it drains the fluid, so the follicle is collapsing. Okay, we cannot see the egg. Egg is microscopic, but the egg should usually come with the fluid and stream by the needle. Now, at the time of egg freezing on the same day, ideally within 2 hours after the eggs have been harvested, we will want to do the vitrification and freeze the eggs. Sometimes we could wait up to 4 hours to do the egg freezing. On the day that, right before the egg freezing, our embryologists will look at the eggs under the microscope. What they're going to do is a little bit of preparation and processing. They're going to strip away the supporting cells of the egg so that they can look at the egg and assess its developmental stage. We want the eggs to be in meiosis too. So it's a stage of meiosis where they are able to be fertilized directly by sperm once they are thawed. So we sometimes will harvest eggs that are premature. They're in meiosis 1 or germinal vesicle, etc. So we have to distinguish those, because these eggs are not going to be mature enough to be fertilized. So we don't freeze those. We'll only freeze mature eggs. But beyond maturity, it would be nice if we can also assess quality, but the caveat is the quality of the eggs is a little bit difficult to assess at the time of the egg retrieval, at the time of freezing. The best time to assess quality is later, when the eggs have been thawed and made into embryos, and we can then do genetic testing on the embryos to assess the quality. But of course, it goes without saying that if we have healthy eggs to begin with, we're more likely to end up making healthy embryos. But if the eggs are already poor quality and not healthy to begin with, it's not going to be able to make a baby. Um, but unfortunately, we don't have the ability to assess quality of the eggs right now. But and because of that, I do encourage patients to try to freeze their eggs sooner rather than later, because age currently is still the number one predictor of how healthy our eggs are. So the younger you are, the more likely your eggs are going to be able to make healthy embryos in the future. So I'm going to go through a little bit of our success rates. Now, this is a published data. It's a little bit old, but I feel like overall, the numbers have not changed significantly. And this study is a very nice way to think about egg freezing success rates. So it's separated, it groups patients by age. So it's age of the patient at the time that the eggs were harvested. So 30 to 34, 35 to 37, 38 to 40, and then 41 to 42, right? And each line indicated the probability of having one child, two versus three. Okay, so let's look at one. And this is number of eggs that we have frozen, and the y-axis indicated the predicted probability. So if you're younger than 35, let's say we freeze 10 eggs, that will give us a 50% probability of having one live birth. And the same 10 eggs, if we use that, has only about 15% probability of having two babies out of those 10 eggs. And it's pretty much unlikely that you're going to have three babies out of 10 eggs. Okay. But in general, for women between the age of 30 to 34, often they make somewhere between 15 to 20 eggs. So let's say if you get a 15 eggs, we're looking at 65% chance of pregnancy. Out of 20 eggs, it's an 80% probability of one live birth. But you also notice that probability of having two babies significantly increased. So at 20 eggs, there's almost a 50% chance of having two babies. Okay, now if we look at age of the woman at the time of egg retrieval is between 38 to 40, seeing 10 eggs is only going to give us a 40% probability of one live birth, but essentially, less than 5 or maybe 5% of having two babies. And 20 eggs here gets us to a 65% probability of one live birth and 20% probability of two. So there's a big difference in terms of probability of pregnancy from the same number of eggs, just based on age difference. But another difference that's not reflected by this graph is how many eggs we expect to get in one cycle. So, because egg count decreases over time as well. So at age 30, we might get 20 eggs in one cycle, but for 38 to 40, our average number of eggs is around 10 per cycle. So for a lot of patients, it takes 2 cycles to retrieve the same number of eggs as one cycle in a younger age group. And also, even if you get to the same number of eggs, the probability of having children out of those eggs will be lower. Okay, so another plug for doing this as soon as you are ready and not delaying. Now, this is, again, outcome for using frozen versus fresh eggs. People have looked at, again, this is a study, initially kind of proof of concept to make sure frozen eggs are safe, that, they're not going to lead to birth defects or make babies that are not healthy. So people have looked at delivery outcome and also baby outcome for coming from fresh eggs versus frozen eggs, and they found that there was no difference in both obstetrical risk and also birth weight, abscess, birth defects, etc. And that's 10 years ago, and now we have had many babies, and worldwide there are probably I don't know exactly how many, but I would imagine thousands of babies, if not more, that have been born from vitrified eggs. And no new studies have suggested that children's outcome is any worse than using fresh eggs. Now, and we probably need to update this number too, but these are from our egg bank. We have a frozen egg bank of egg donor eggs, and we have already had over 300 live birth babies born from frozen eggs. We also have, over the last decade, have frozen for patients, over 10,000 eggs for patients themselves who want to use them in the future. So so this is two separate programs. We have a program for egg donor. It's like an egg bank. And then we have program where patients are freezing eggs for themselves. So we have a lot of data accumulated over the years from both egg donor frozen eggs as well as patients' own frozen eggs. Obviously, age groups are different, but we find that everything I've talked about up to this point apply both to donor eggs as well as patients' own eggs. Now, how do we use the eggs in the future when you come back? First, we do some assessment, of course, making sure the uterus looks good. We do the sperm test. We will do some genetic testing to make sure that both egg source and sperm source don't have common, hereditary or recessive genetic conditions. Then we will warm the eggs, fertilize eggs with sperm. Typically, we do ICSI, which stands for intracytoplasmic sperm injection, which is just injecting one egg with one sperm to allow them to fertilize. And after they've been fertilized, the fertilized eggs will be cultured in the laboratory for up to a week so that the one cell fertilized egg has a chance to grow, multiply, and divide, and grow to blastocyst embryos. And typically, blastocyst embryos will have over 100 cells. And that's when we now will biopsy the blastocyst by taking 2 to 5 cells out of that embryo. And we send the embryo biopsy to the genetics lab to test the chromosomes. And that option will let us rule out Down syndrome or any other chromosomal abnormalities that can lead to miscarriage or pregnancy complications. And also it will improve pregnancy rates when we do the transfer. Most patients end up opting to do genetic testing on their embryos that have come from frozen eggs. And this to do that, we also end up freezing the embryos because the genetic testing takes time to come back. So it's nice that, just logistically, it just naturally lead to thawing eggs, creating embryos. Embryos are frozen. It's kind of completely independent and separated from our cycles. So we can first, create embryos and see how many of them are healthy. And with that information, patients can then decide, okay, they're going to go do an embryo transfer into the uterus, or maybe we don't have enough embryos and we can do another IVF cycle. So it creates a lot of flexibility for patient at this stage to make some additional decisions about their family planning. And embryo transfer just refers to placing the embryo back into the uterus. Again, in this case, it's often a frozen embryo that's been genetically tested. To do that, we will prepare the uterus. If a woman is having regular menstrual cycles, we typically just time the cycle, time the transfer to their ovulation. Typically, it's about a week after ovulation, we put the embryo back in. If patients have irregular cycles or if they're postmenopausal, we can use medications to manage the uterine condition to allow for a successful transfer. So now, because like I said, we've been, over the last decade have frozen over 10,000 eggs, and many patients have come back over the years to thaw their eggs. So it's not just enough to freeze them. We have to wait until they thaw and transfer and see if, they make a baby. So it takes a long time and a lot of patient information to be able to put together a data set. Now, from our own data, I can tell you that it takes multiple eggs to be able to make a chromosomally normal healthy embryo, or in other words, each egg has an associated chance of pregnancy or associated chance of being normal based on the age at which the eggs are taken. So for egg donor younger than 30, typically each egg has a 23% roughly, so 25% chance of making a healthy embryo. So in other words, you need 4 eggs to make 1 embryo. Okay. And again, usually egg donor, in one cycle, if you're younger than 30, you can make 20 eggs in one cycle, and in which case you'll get multiple embryos. For women younger than 35, between 30 and 35, we're talking about 1 out of every 5 eggs, so 17%. Between 35 to 37, it's roughly 1 out of every 7 or 8 eggs, so 12%. And between 38 and 40, it's a little bit less than 10%. So you need at least 10 eggs to make one chromosomally normal embryo. So if you want to, have a secure chance of having a baby, honestly, sometimes 1 embryo is not enough, and you're going to need to bank, potentially 20 eggs or 30 eggs in order to make 2 or 3 embryos. And then it becomes a little bit more challenging for women in their early 40s, where each egg only has about 6% chance. So you're going to need 20 eggs to make one healthy embryo. And 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 again, you couple that with the fact that for women in their early 40s, oftentimes they only make 5 to 10 eggs per cycle. To get to 20 eggs, it might need 3 cycles to get there. So, again, it becomes a little bit harder to achieve a very high success with egg freezing. I would say most of our patients nowadays who come in to freeze their eggs are kind of in this range. Okay, so early to mid 30s, which I think is great, is a good time. You should be able to get a good cycle and get a good number of eggs that will have a very decent chance of pregnancy in the future. And oftentimes patients will still opt to do a second cycle if they really want to, have enough eggs for maybe a second baby, etc. So I basically just kind of went over the slide. This is just the reverse of the slide before. So for egg donor, it takes 4 eggs to make one healthy embryo. For 30 to 35, it's about 1 out of every 5 or 6. 35 to 37, 1 out of every 8. 38 to 40, 1 out of every 10, and this is 1 out of every 15. So why freeze eggs at PFC? What I think I've already mentioned a little bit because of our experience. And egg freezing is a very technically challenging procedure, and it requires a lot of finesse. Now it sounds simple; it's just one process, but the egg is one cell, right? And it's very fragile. So if you don't treat it right, um, one, it may not survive the freeze and thaw process, and two, it may not be able to create a healthy embryo in the future. So, and our decade of experience and really allow us to fine tune this process, and also giving us all this data to really say, okay, to basically put, you know, to prove that this works and this is what you're going to get. And these are backed by real data from real patients at PFC from San Francisco, right? It's not some national data from people who are having completely different demographic information or physical characteristics. So it's very relevant. And like I said, we've got hundreds of babies that have already been born. And we also we provide full service fertility treatment. So egg freezing is one aspect, but obviously in the future, when you thaw eggs, you're going to need to do the second half of IVF. You're going to need to do embryo transfer if a patient needs to use, a gestational carrier, or it kind of is the beginning of the fertility journey. And you want to be at a practice where they have experience, not just with egg freezing, but with every aspect of the fertility journey. So now, after this consultation or this webinar, if you want to proceed and become a patient at PFC, definitely reach out to our new patient coordinator, and they'll schedule you for your first consultation. Usually it's online. We'll see each other over video and spend a good 30 minutes discussing your history, your fertility plans, any treatments you've already had, any other relevant information. We can go over a little bit more about, the next steps. But it's really nice to be able to have dedicated 30 minutes to really delve into your particular situation. And then the second part of our new patient experience is you coming in and meet the physician of record and actually get that ultrasound where we can count your eggs. And then we'll set you up with follow-up appointments to start the journey. Now, I can take some questions.
Yeah, thank you, Dr. Lee. So if you have questions, go ahead and submit them through the Q&A function at the bottom of your screen. We'll save a couple minutes here, and yeah, go ahead and send any questions you have through. And from earlier, Dr. Lee, a patient had a question regarding what OCP stood for.
Oh gosh, I'm sorry. Yes, it's oral contraceptive pills, so birth control pills.
Great. Okay.
I see a question here. Is there?
Yeah, so this is more of just a treatment style question, but for those of us who live far away, how many of the labs and ultrasounds can be done at another facility?
Ah, yeah, so we do want the initial physical appointment because we do have to see you in person in order to establish a patient-physician relationship. So then we can order labs and stuff like that. Um, but all the other labs can be done locally. We typically will give a blood test requisition. You get it, at LabCorp Quest or your local hospital. For out-of-town patients during treatment, we also do allow outside monitoring where you can do, maybe 2 or 3 of the ultrasounds during the cycle locally and then come for the last week of your treatment, including the egg retrieval.
All right, and then we have a follow-up question to OCP. At what point in the process does a patient need to stop taking OCP?
Great question. Um, Super simple, and it's really nice for patients to continue their birth control because then they can just schedule their egg freezing journey at any time, that fit their schedule. But basically, you stop the birth control pills 3 days before your baseline ultrasound.
Okay, and then another question, what is the time frame from consultation to retrieval? How long does that take?
Mhm. I would give about a month for the preparation part from the initial consultation to starting of the cycle, and then the cycle is about 2 weeks.
All right, any other clinical related questions regarding treatment plan, uh, any of the subjects we discussed today? Okay, so for any follow-up questions, do feel free to, oh, we did have one more. So for patients with PCOS, do we need to take additional, looks like additional medications when getting off OCP?
if you're already on birth control for PCOS, it's actually a very good type of management. I usually will just stop the birth control and then start the cycle, 3 days later. If you have not been on birth control, your cycles are not regular. Sometimes we might induce a period with progesterone, um, or we can just start the cycle randomly. The I for patients with PCOS, I also have a different panel of labs and hormones, and also looking at